McGill-wide Department of Medicine Grand Rounds. Again, thank you so much for attending, and apologies for those that had troubles getting in with passcode issues. Before we go further, I'd like to acknowledge that McGill University is situated on the unceded territory, the Kenyan Gahaga, and is located on land which has long served as a meeting site and exchange amongst Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. I'd like to once again extend my thanks to Dr. Chen Tourneau, our Associate Chair of Education, for organizing these McGill-wide medical grand rounds and for lining up a fantastic series of speakers. Today, Dr. Shojania, that Dr. McDonald will introduce shortly, Dr. David Naylor, Dr. Joshua Bengio, and we have another tentative speaker. I'm not sure we're quite at the point where we can say that we've got.
We can announce it. It's Jill Horton.
Jill Horton, great. So I will now turn the virtual podium over to Dr. McDonald, our Associate Chair in Quality Safety, a clinician scientist with a quality safety focus, and Associate Professor in the department, who will do the honors and introduce Dr. Shojania and moderate the session this evening. Dr. McDonald?
Hi, everybody. Welcome. I don't have the host capacity to start my video, but maybe while I'm doing the introduction, you can turn my video on. So welcome, everybody. It's my great pleasure to introduce Dr. Kaveh Shojania, who is a professor and vice chair of quality and innovation in the Department of Medicine at the University of Toronto. His research has focused on identifying effective strategies for improving healthcare quality. So he attended medical school in Winnipeg, followed by a year at UBC, then completed his residency at Harvard's Brigham and Women's Hospital in Boston. And then after a fellowship in the University of California in San Francisco, he stayed on faculty there for several years, but we're lucky that he returned here to Canada. He held a Canada Research Chair in Patient Safety and Quality Improvement for close to a decade, 2004 to 2013. He's widely published in journals such as New England, JAMA. He has over 20,000 citations of his work with an H-index of 69. He also helped shape research publication in healthcare quality through his work as editor-in-chief at the BMJ Quality and Safety. And actually during that time, the journal's impact factor rose quite substantially. So it was just under 2 before he started working, and it increased to over 7, such that it's now the second highest impact among the 90 or more journals that are in its category. More recently, Dr. Shojania has become interested in ways of achieving improvements in actual health instead of just improving healthcare. So he's doing this by collaborating with groups who are addressing the social determinants of health, as well as obvious threats to health and healthcare, such as the climate crisis and systemic racism. So welcome, Dr. Shojania.
Thanks so much, Emily. And thank you, everybody, for joining at 5 o'clock on a cold fall day. Here, let me just get ready sharing my screen here. And sorry, it always takes me a minute to, I know I have to swap. There we go. Okay. So I've given this talk, or versions of this talk, over the last 6 months. It's still a work in progress. So I'll appreciate any feedback about some of the ideas. I'm certainly still not sure what to do with some of them myself. I also just want to make clear that, and you'll see that I'm not talking against any one type of research, but rather the targets of that research. And without further ado, I'll sort of get into just saying that I don't have any conflicts. And my title alluded to matching our research priority to the massive crises we face. I think we all have an idea of what those crises are, but just to be clear, I'm referring not just to COVID, but the near certainty of future similar pandemics, the climate crisis and collapsing ecosystems, structural violence against racialized groups, worsening income inequality, which is really approaching levels last seen under feudalism, and the opioid epidemic, which I think, as we all know, in parts of Canada and the US, lowered average life expectancy even before COVID did so. Now, because of these crises, many have pointed out the importance of not returning to pre-COVID normal. I also want to mention, as many of you in the wake of COP26 know, a month or so ago, or maybe it was almost 2 months ago now, about 200 journals simultaneously published this article on the importance of a call for emergency action to limit global temperature increases, restore biodiversity, and protect health. And they called on governments to make fundamental changes to our societies and economies are organized and how we live. Now, this was a crucially needed call and a much welcome call for action, but why no fundamental changes to how we organize healthcare or what we prioritize for biomedical research? It's hard to imagine how the main types of basic and translational research we have been conducting or our approaches to quality improvement will deliver worthwhile benefits in the face of the scale of the adverse impacts of these massive crises. Why has there been so little questioning of research priorities? Well, I think probably because the mainstream view holds that biomedical research routinely produces important advances. We're just not very good at translating them into practice in a consistent and widespread manner. And this simple diagram indicates that model, the idea that we produce good things, we come up with the evidence and then either diffuse or implement them, or our knowledge translate them into practice. That's why we use the word KT in Canada so common, and some people just loosely bundle those all together into quality improvement. And I include that citation at the bottom not just to say, look, I wrote something, but just indicate that I actually believed this model until relatively recently. I've come to believe there's two fundamental problems with that model. First, most improvement interventions, when evaluated rigorously, either do not work or achieve small gains. Larger gains tend to occur only for very narrow targets. More fundamental, though, is that most clinical interventions also turn out not to work or to confer small benefits, so are not that worth translating into practice anyway. Now, I realize that second claim is more controversial. Let me just briefly turn to the first one. Some of you who are my age or older may remember in the CMAJ in 1995, there was this systematic review with the title No Magic Bullets. It was actually a play on the magic bullet of Paul Ehrlich and the antibodies and antibiotics that he was talking about in the late 19th century. And what they did in reviewing over 100 interventions aimed at changing professional practice, they found that there were no magic bullets. Most things didn't work very well. They achieved modest at best improvements. 25 years later, it's not much different. What the bullets on this slide refer to, they're each from more recent meta-analyses, including the top one from computerized decision support that I was involved with, just came out last year. And each of these results shows the absolute improvement in the percentage of patients receiving recommended care. And so what I'm pointing out is that these common improvement interventions are really achieving tiny, tiny absolute improvements in the percentage of patients receiving the care that we think they ought to receive. To make absolutely clear why 5% is so disappointing, I'll use the results of that more recent meta-analysis on computerized decision support. Across 122 randomized controlled trials with 1 million patients and almost 11,000 clinicians, a median of 39% of patients in the control group received whatever the desired element of care was. The meta-analytic result was the typical increase was 5.8%, call it 6, 39 plus 6 is 45. It's basically over half of people still don't receive the desired element of care. Now, obviously, there are occasionally times where we see more robust effects, like this example of a kind of a nudge to the order set in the emergency department so that people wouldn't order so many urine cultures. And you can see that there was a relative reduction of about almost 50%, which is definitely nice to achieve. But for every one of these successes, there are failures of the same sort of approach. And again, these projects address very narrow targets. We'll never get where we need to be if we keep needing to do hundreds and hundreds of these projects. This problem of narrow targets comes up all the time in quality improvement and actually in clinical research too. Here's an exemplary sort of KT trial in the New England Journal a few years ago. I really want to emphasize this was exemplary. They had sort of piloted, the intervention was targeting the problem of high-risk prescriptions for NSAIDs and antiplatelet agents. And the intervention involved educational outreach visits, weekly identification of patients. They were incentivized to review these cases. And the bottom line, you can see in that middle panel, there's a robust 40% reduction in these high-risk prescriptions. And actually the third panel shows that it was sustained over an 18-month post-intervention period, which is fantastic, except that the intervention affects only 3.7% of patients taking these targeted high-risk medications. We can't possibly play a game of whack-a-mole in which we keep going after these narrow targets, sending report cards from multiple different aspects of care, then having the clinicians who work receiving these report cards develop quality improvement projects to make sure that they're actually, achieving the desired result. Now, the examples I've given before have been for common interventions applied across multiple targets. This is an example showing that even for really common chronic diseases like diabetes, we're not very good at improving care. I was the senior author on this meta-analysis. It's almost 10 years old. It came out in the Lancet. Basically, across 140 randomized controlled trials, the improvement strategies reduced the hemoglobin A1C by about 0.37%. And as we all know, most people who need better glycemic control are at more like 8 or 9%, sometimes 10 or 11%. So 0.37% is not going to really help anyone except those who are already almost at the targets. And the other endpoints were also almost homeopathic effects. Now, that was almost 10 years ago, but some of you may have seen a few months ago in the New England Journal, this paper came out. And the highlight for the paper was that we have actually gotten worse compared to the first 10 years of the early 2000s compared to 2010 since. But I would say that the real headline is that only 50% of adults with diabetes achieve target control for hemoglobin A1C, blood pressure, or lipids, and only 22% achieve control for all three. So despite all of the massive advances in like oral medicines for type 2 diabetes, new types of injectable agents, we really have not made any kind of serious impact on the number of patients with achieving guideline targets. So that's basically the first point, which, as I said, I didn't want to dwell on because I think the second point is more controversial. And that is that the same characterization that most things don't work out once it's rigorously evaluated or they achieve or address narrow targets applies to clinical interventions. So that it's not really worth translating them into practice anyway. Now, I realize the development of COVID vaccines in less than a year gives the impression that biomedical research routinely produces useful solutions to pressing health problems. But I think we all know when we read journals every week or skim the tables of contents, most of these articles are reporting that something we hoped would work either doesn't work at all or has a very large number needed to treat. Here's a study backing up that qualitative impression. This was a kind of cute little study in PLOS One that was a before-after analysis of large cardiovascular trials funded by the NIH, and they used the cut point as the year 2000 when clinical trial registration became mandatory. So prior to 2000, 57% of these trials reported a positive outcome. Afterwards, once you could no longer claim that your primary outcome was whatever you wanted it to be, only 8% of trials were published. There happened to be a paper in the New England Journal on another topic that I just stumbled across that actually included a list of all these large cardiovascular trials just published in the New England Journal or JAMA. And even with that massive selection bias, there was still only a positivity rate of 25%. So despite massive investments in cardiovascular research, most therapies, once rigorously evaluated, don't pan out, as with most medical research. Even when they do pan out, they have small effects, even for cornerstones of clinical therapy like statins. Up to date, so this is not some fringe publication here, up to date states that among patients with established atherosclerotic cardiovascular disease, 33 to 100 patients need to take a statin for 10 years in order to prevent one CVD death, MI, ischemic stroke, or recurrent ischemic event. And notice that that isn't even all-cause mortality, it's just cardiovascular death. And actually, if you look at, which is sort of subjective, so there was actually a really elegant meta-analysis a couple of years ago that used modeling to come up with the Kaplan-Meier trial curves from trial data, and looking at trials with at least 2 years of follow-up and at least 1,000 patients, they shown that statins postponed death by 10 days in primary prevention trials and 17 days in secondary prevention. Imagine if instead of a vaccine for COVID, we spent billions of dollars a year on a medication that 33 to 100 patients needed to take for 10 years in order to prevent one COVID-related hospitalization or death. We are so used to seeing therapeutic effects reported in terms of odds ratios and relative risks, often for disease-specific endpoints, that we forget the rarity of medical interventions that materially improve the length and quality of life. I could give other examples, but for the interest of time, I'll just make this more general point that the primacy of randomized controlled trials in medicine itself reflects the effects of most interventions. The need to ensure balanced distributions of known and unknown possible confounders and use various forms of blinding reflects the reality that all of the following have larger effects than most medical interventions: chance, psychological effects on patients, clinicians, and outcomes assessors, and confounding socioeconomic factors. In fact, some of you may remember that almost 20 years ago now in the BMJ Christmas issue, there was this tongue-in-cheek systematic review of parachutes to prevent gravitational trauma from jumping out of a plane without a parachute. And the joke here was supposed to be on rigid EBM advocates calling for randomized controlled trials for interventions with obvious benefits in observational studies. But the sadder joke is on the whole of biomedicine for producing so few parachutes. So in a nutshell, that's the basis for these two fundamental problems that I see with our model. Most improvement interventions, when rigorously evaluated, either do not work at all or achieve small gains, or they address narrow targets. And the above also turns out to apply to most clinical interventions, so they're not that worth translating into practice anyway. But if this were true, surely we would have noticed some concrete signals in population health. Well, we actually do have such signals. Here's a particularly striking one that I came across a couple of years ago. As many of you will recognize, this is this London tube map, but with the tube stations showing the average life expectancy in the surrounding neighborhoods. Now, as you can see, let's say looking along that red line from west to east along the middle, there are stations with really high life expectancies, like 90 and then 96 years. And then one stop later, it's down to 85. And then if you go in either of two directions, it's down to 79 years. So that's 17 years of life in just two subway stops. There are not many biomedical interventions that have that kind of impact on longevity, except public health measures and hygiene and standard of living, the things that we've mostly watched be eroded as we pursued an agenda entirely dominated by precision medicine. Now, I think we all know there are massive economic inequalities. We live in a world where individuals have greater personal wealth than entire countries. But I don't think everyone appreciates just how massive and concrete the health impacts produced by these socioeconomic disparities are. This photo essay was actually in the New York Times almost exactly a year ago. Profile. So a number of cities in the United States have neighborhoods where there is a delta of at least 20 years between two neighborhoods. And the worst is Chicago, with these two neighborhoods that actually have a 30-year gap in life expectancy. And I think you can see from the pictures the differences between these neighborhoods, and certainly from these bullet points, 5 times the median income, 5 times the house price, 30 years longer of life expectancy and lower COVID cases at the time as well. Now, it's not as egregious in Canada, and we don't have as striking a pictorial representation, but there have been similar studies in Canada showing, for instance, the Code Red study in Hamilton, a similar one in McMaster, and where I grew up in Winnipeg, the difference between the richest and poorest neighborhoods is 18 years. Now, at a national level, you have to go back to 1940 to have 18 years less of life expectancy. Now, many of the people who live in that poorest neighborhood of Winnipeg are First Nations. They have the starkest examples of the impacts of health on, place of residence on health. I've used the example of boil water advisories, which has been in the news again lately because of the situation at Iqaluit. But obviously I could have mentioned suicide risk or any number of other health risks. Some of you may have seen this before. This is a graphic that the Canadian Medical Association produced, I want to say about 15 years ago now. And while one might quibble with the exact percentages, I don't think you can quibble with the qualitative picture overall, that what we prioritize for biomedical research does not reflect what makes most of us sick. Don Berwick was very famous, sort of one of the founders of the whole quality improvement in healthcare movement, had an essay in JAMA last year, The Moral Determinants of Health, in which he wrote that except for a few clinical preventive services, most hospitals and physician offices are repair shops trying to correct the damages of causes collectively denoted the social determinants of health, referring to conditions of birth and early childhood, education, housing, job opportunities, air and water quality, and so on. But these are socioeconomic problems, not healthcare problems. Well, maybe, but healthcare keeps consuming about 40% of provincial budgets. If we take all the money and don't do anything about the social determinants of health, how will we achieve any useful improvements in population health? Healthcare as currently organized does not improve basic health outcomes for much of the population, and this will worsen as economic deprivation becomes more widespread and as the impacts of the climate crisis become more frequent and more devastating. But some people might also say, but these are not really research problems. Well, I'd say it's actually not at all clear what the most effective or efficient strategies are for improving the social determinants of health. That's why, for instance, there have been trials of universal basic income. What is clear is that the social determinants of health all have greater impacts on health than do individual biology or the medical therapies that consume most of the massive budgets for healthcare delivery and receive almost all of the funds for research. I mean, I think we've all seen examples of what that type of research on the social determinants of health might look like, but just in case you haven't, here's an example that was somehow miraculously published in JAMA a few years ago. It's actually a Canadian study involving 4 Canadian cities in trying to help homeless adults with mental health issues. And the intervention basically included rent supplements and some case management services. And across all 4 cities, there were absolute increases in the percentage of days stably housed of 30 to 50%. In addition to the social determinants of health, whether we address them or not, I think we could also just generally have much more research on disease prevention. Some of you may have heard or come across Dan and Chip Heath. They're management professors at Stanford and Duke. They wrote a couple of really well-regarded books called Switch and Made to Stick about really sort of groundbreaking transformational innovations and so on. So Dan Heath's most recent book came out early this year, and it's called Upstream. And he wrote that the US health system is designed almost exclusively for reaction. It functions like a giant undo button, but it's hard to find someone in the system whose job it is to address the question, how do we make you healthier? Most agree that an ounce of prevention is worth a pound of cure, but our actions don't match our words. The book has a number of concrete and inspiring examples. This was one of them that the context for the intervention is that among racialized young men in large American cities, homicide claims more lives than the next 9 leading causes of death combined. Early on, a nonprofit group started analyzing some of these deaths and found they were not gang related, that they were disagreements which escalated rapidly in the context of access to guns and sometimes drugs and alcohol. So they gradually developed this intervention that focused on impulse control, conflict resolution, and so on and so forth. And actually the University of Chicago Crime Lab got involved. And now there have been 2 randomized controlled trials documenting total arrests reduced by about 30%, violent crime by about 45 to 50%, and high school graduations by 12 to 19%. And I think we all know what an important impact that education can have in terms of a protective effect. It's not just the United States. This is actually a Canadian study from the Emergency Medicine Journal, from one of the emergency medicine journals. It was actually a feasibility study just to show that they would be able to conduct a randomized controlled trial of an emergency department violence intervention program. They definitely demonstrated the feasibility of evaluating because they enrolled 130 youth presenting to the ED with violence-related injury. And they actually were also able to report like a pretty intriguing signal of absolute reductions of 10% in repeat violence-related injury, reductions in new interactions with the justice system. And they even did this without any increase in the ED length of stay. Now, this type of work seems daunting to take on at all, never mind outside of a research setting where there's really no supports for it, which is why I found this quite inspiring when I came across this article in the Globe and Mail a few months ago, describing the work of Drs. Louisa Marion Bellemare and Julie Sampson working in Timmins, a mining town in Ontario, where they came to realize that the per capita rate of fatal overdoses from opiates was twice that of Vancouver's and 4 times the provincial average in Ontario. They noted a number of obvious shortcomings in terms of basic resources, including that the nearest detox facility was an hour away. The rapid access addiction medicine clinic was only open 3 days a week and required a formal referral. And the police maintained the historic approach of letting addicts languish in lockup while they went through withdrawal without any supports. So these two doctors gathered the facts. They met strategically with different people in the city and finally made a very impactful presentation to the city council. And through their efforts and those of the others they engaged, a lot of changes were made, including the hospital putting in some detox beds, the expansion of the RAM clinic and not requiring a formal referral, and even a new police unit. So the point is that there's obviously lots of work left to be done, and achieving real impact does take time, a point that I'll return to in a few minutes. But before I do so, why have we not tackled the social determinants of health or other prevention-oriented goals? Well, for one thing, clinical training prioritizes short-term goals of fixing and curing, and academics reward short-term signs of impact. And it's easy to view prevention as someone else's job. Like it's clear whose job it is to take care of the obese patient who has diabetes or sleep apnea or whatever the case may be, but it's not clear whose job it is to make sure that there are fewer obese people or people with diabetes in the first place. There's obviously massive commercial interest in the current approach, and it doesn't help that the dominant political ideology emphasizes individual actions and accountability over social forces. And for those of you who don't know the context of the little picture below, that's Margaret Thatcher and Ronald Reagan standing at a podium together. And Margaret Thatcher famously said, as we all know, there's no such thing as society. I mean, what an outrageous statement, but it shows that the leader of the UK could make that, shows you the degree to which we prioritize individuals and similarly individual biology over the reality of massive social forces that have concrete impacts on people's health. So what might we do about this? Obviously, I don't pretend to have the answers for such a major problem, but the first thing we need to do is acknowledge we have a problem, a major mismatch between the dominant causes of poor health and what we prioritize in biomedical research as well as healthcare delivery. Probably need more policy and advocacy work, leveraging the resources and social capital enjoyed by healthcare. Might help to tackle some complex structural issues in our own backyard, just as for practice. For instance, why not address major pay differences within and across specialties? We're living through a pandemic that has involved infectious diseases and public health, which have not been prioritized, as far as I know, on anyone's strategic plan or in reimbursement. I mean, do we really want to just go back to saying that some subspecialties are worth more than others? And the same for advocating for better support for other colleagues in other healthcare professions. And I think finally, we need to rethink our research priorities and our framework for impact. If we value better health for the whole population, we cannot keep directing most of our resources at activities with so little chance of achieving that goal. To show some concrete examples, so take dementia. There are 121 agents in clinical trials for the treatment of Alzheimer's, 29 currently in phase 3 trials. The likely outcome is a statin equivalent, a medication which 30 to 100 patients with cognitive decline need to take for one person to derive worthwhile benefit. Why would we not invest comparable amounts of research or more research on the obvious structural problems and how we care for the elderly, better models for caring for patients in the community, develop and refine new models of long-term care, and obviously optimal staffing levels and payment schemes for healthcare workers in long-term care? Here's a concrete example involving the climate crisis. That top bullet refers to a paper that came out in the New England Journal, I think in around October of 2019. So just as COVID was starting to rear its head in China, they looked at small changes in ambient particulate matter, which basically pollution, in 652 cities. And they were able to show that within 48 hours, there was a 0.5% increase in all-cause mortality. There was actually an elegant study in the BMJ from Canada just a few weeks ago showing 5-year mortality up to 13 years lower among Canadians who moved from highly polluted to less polluted areas, and the reverse for people who moved from less polluted to highly polluted areas. We also have seen articles that came out last year in the wake of the wildfire season last year showing increase in ambulance dispatches within a few hours of exposure to BC wildfires. Similar results in California and Australia even showed excess mortality. And actually the WHO and the UN have emphasized that global mortality from poor air quality is now basically the same as tobacco. So in that context, why on earth are we still primarily researching more inhalers and now even monoclonal antibodies for asthma and COPD, and then clinical trials with endless permutations of these inhalers? Why not collaborate with people in other sectors to work on strategies to reduce pollution, improve air quality, and also to make sure the health system will be resilient enough to handle predictable surges now in patients from poor periods of particularly poor air quality? Now, I realize this will all take time. And that's kind of easy to get depressed about, which is sometimes why I think of this quotation. People tend to overestimate what they can accomplish in 1 year, but underestimate what they can achieve in 5 to 10 years. The hope that that quote brings me was brought home again last year when I read this unusual and extraordinary book called The Ministry for the Future. The author, Kim Stanley Robinson, some of you may know, won basically every science fiction award for his Mars trilogy in the 1990s. This is not that type of science fiction, though. It takes place now and over the next 30 years. It opens with horrific depictions of how bad things will be, including a heat wave in India that kills 20 million people. But then plausibly and inspiringly, it depicts the ways that different people make necessary changes to various aspects of society. The action spans the globe with popular uprisings, eco-terrorism, asymmetric warfare, student debt strikes, geoengineering, and even a new type of carbon extraction-based currency. One terrific aspect of the book is the way it intelligently deals with the problems of massive financial inequality and the ideologies of racism and cultural displacement, which have contributed to so many of the crises we face, not just the climate crisis. And on that note, that so many of the massive crises we face ultimately have to do with questions of equity and othering, I thought I'd end with this passage from an essay that the novelist and activist Arundhati Roy wrote in the Financial Times last year. She wrote, "Historically, pandemics have forced humans to break with the past and imagine their world anew. This one is no different. It is a portal, a gateway between one world and the next. We can choose to walk through it, dragging the carcasses of our prejudice and hatred, our avarice, our data banks and dead ideas, our dead rivers and smoky skies behind us, or we can walk through lightly with little luggage, ready to imagine another world and ready to fight for it." With that, I'll say thank you and for your attention, and I'm happy to answer any questions. As I said, I do know it's 5:30 on an evening, so I wanted to keep things relatively short. Here, let me just stop sharing my screen.
Thanks, Kaveh. I'm getting a lot of feedback that this was a very mind-opening talk and that it's made people think about the research that they're doing in a whole different way. So first of all, just wanted to start with that. And then we have a couple of comments in the chat. Luis Pilat is saying that some of these social determinants are gendered, and then goes on to say, what are your thoughts about social prescribing?
If I understand, there actually was there was a nice essay in the CMAJ by, actually, I don't know him, but he's in the Department of Family Medicine here just a week or two ago. And a few other people have been talking about sort of upstream clinical practice too. I assume that maybe Dr. Louise is referring to that too. I certainly support it. The problem is that comes up, I'm not sure though if this is what Louise is saying, is like a lot of people will say they have someone with diabetes who's some obesity or something, they want to recommend that physical activity or something like that. The problem is, the reality for most people is that it's difficult to, while you're working 2 low-paying jobs, to go exercise. And when you live in a neighborhood that's not at all walkable, there's so many, or that you live in neighborhoods where there's like not much fresh food and this and that. So I guess what I'm trying to say is, yes, we could for sure try starting with the type of thing that I think Louise is referring to, but I think that that will be very difficult to do if we don't also advocate for and actually collaborate with people in other sectors to make sure that it's actually feasible for people to follow our social prescriptions. That's how I guess I would put it.
Yeah, fair enough. I read Natalie Diane says she read a CBC article about a BC doctor who started diagnosing his patients with climate change. So it's kind of funny.
Actually, there was a case, I think it was the news in the UK a couple of years ago, where there was a mother who had fought for years to have the coroner in London acknowledge that her 10-year-old daughter who died of asthma had actually died of pollution, and the coroner finally agreed. So no, I think this is going to be increasingly, and there was a review article in the New England Journal a couple of years ago on sort of heat-related and climate-related clinical syndromes too. So I do think that there's various prongs that people are trying to use to really get people's attention. I mean, I know it isn't just about the climate crisis, but I have to say, like, one of the George Monbiot on The Guardian, if today or yesterday, pointed out that if we want to have any chance of meeting that 1.5 degree threshold that people keep talking about, we have to reduce greenhouse gases by 7% a year, which is actually more than went down even at the height of lockdowns. So that's just a sense of the staggering transformation we need. And I guess what I'm trying to say is that I don't know that, I'm not saying we shouldn't be doing basic science or translational work, but I am saying I'm not sure that it all should be directed at new monoclonal antibodies for advanced cancer when we have this terrible, terrible crisis on our way.
My own research is in deprescribing, and I never thought that I'd be able to really link climate change with deprescribing. But I recently found out that there's a long-term care home where 70% of the residents have a PRN order of opioids. And what I didn't realize is that in order to have that stock on hand, it's not like you have 10 pills in the home, but every month the pharmacy has to prepare enough PRN opioid, package it, transport it, and then keep it on hand. And then at the end of the month, about 90% of it gets wasted.
Yeah.
There's a question from Dr. Chen Tourneau. So she's saying that she's rethinking the entire, if we're going to be rethinking the entire medical industrial complex, where do we start as professionals in academic medicine?
Oh, I know I'm just trying to start the conversation. Obviously, I wish I had some great answers. I will say, and I see that one of the other comments about capitalism, I often get a comment about that. I mean, actually, the reality, of course, is capitalism has driven this. I mean, that is, and it's depressing to think, some of you may have heard this line, it's attributed to two different people, but the line is basically this: it's easier for most people to imagine the end of the world than it is to imagine the end of capitalism. It's very sad, but true. But Ursula Le Guin, the science fiction author, actually wrote a rejoinder to it, which is that, we once could imagine nothing other than the divine right of kings. So obviously, sometimes attitudes do change. That's what I found so inspiring about that Ministry for the Future. But I mean, it's amazing the number of people who told me that book blew them away and had discovered it. It really does depict in a plausible way how things might actually change, even when it seems so entrenched.
Yeah, I think we're all going to add it to our reading list for sure. Kabir Dasgupta is saying, is the answer not so much related to research, but rather advocacy? And she says this as a researcher and an intern married to a family doctor who occupies himself with peace activism, refugee health, and social justice issues.
No, I think it's a really great point, and I don't think we don't know how to do activism or advocacy, or sometimes we have people who are colleagues who have somehow wandered into it and learned. I think we've seen also, like in social media a few years ago, people started recognizing which of their colleagues were sort of good at Twitter, and they would sometimes teach people how to be better at it. I mean, maybe we could do that for advocacy. I will say also that I think a type of research that we need to do a lot more is the social sciences about shaping public opinion. I mean, really, we know big pharma, big oil, big tech, they all harness those things. We're like the only people who don't. We're like, oh, that's too, like, I mean, when COVID vaccine, like, here's the basic science that everyone champions, works out, and it doesn't achieve its full potential because it's undermined by a backlash of public opinion. And by the way, this is not a new phenomenon. This is not just because of the partisan politics now. I remember reading an interesting article last year on the history of pasteurization, which I'd forgotten took 50 years to implement. So Pasteur, just to remind everybody, was like 1865, I think, when he discovered the process. In the early 1900s, it was still not at all practiced in North America. It actually required one of the co-owners of Macy's, one of his children died of unpasteurized milk when he was like 1. And so he started championing it. He even set up a lab and gave away free pasteurized milk and actually supplied an orphanage with pasteurized milk. And the mortality at the orphanage dropped within months. And it still took till the 1920s. And a lot of people's reactions were very similar to anti-vax stuff. It's like, this is polluting our bodies and this and that. So there has long been a problem with, basically, if something works well, it's going to bother somebody. So I think we need to figure out ways. I mean, it's interesting that there's a whole body of research, as we all know, on patient-clinician decision-making and shared decision-making. We need to recognize that we probably need a science like that for shaping public opinion. Like, I know it may sound creepy, but again, like you can bet Amazon and Google are doing it, and so are big pharma. So it's kind of crazy. In fact, academic detailing was the one time when we decided to take a page out of Evil Pharma's book and start sending people into people's offices and telling them this is what overprescribing looks like. You don't need to do this, that, like one of the implementation things, as you know, Emily. So we do need to recognize that other people are taking advantage of these sciences, and we need to do more of it in healthcare. If when we do have a big success, it's going to achieve its real benefits.
Yeah, I mean, along those lines, Mark Roger is saying maybe we need to integrate advocacy, which is one of the CanMed's roles, deeper, more into the UGME and the PGME program, so that future physicians feel more comfortable with, just identifying and tackling some of the social determinants of health. Mike Libman is saying, along the lines of what you were saying about the vaccination and Pasteur, that vaccination might be the most cost-effective intervention that we have for treatment or prevention in all of medicine. And yet, like, really significant segments of the population seem to reject it. I think just confirming what you're saying. Kevin Schwartzman is saying one thing we can do in academic medicine is to rethink our incentives. So for example, intense pressure to publish repeatedly, quickly, that's how we have to compete for grants and promotion versus more meaningful clinical and research initiatives done with communities. But that might require years to establish and run and set up. And it requires more stable funding, bigger time commitments, and that's not really how academia is set up.
Yeah, no, that's a great point. We're trying to do, I obviously don't know the answers, but I'm trying to work with, some of the leadership at U of T. And one of the things that we are trying to deal with is exactly that problem, that when you're starting out, like once you're in mid-career or more senior, then you can almost afford to do research that might actually be worthwhile. But then before that, you basically have to focus on, like, is this project risky? Am I likely to be able to get this, trial quickly done and published in a decent impact journal? And so you really are trying to quickly tick some box. It's maybe worse in the United States than it is in Canada, where, like, if you don't have your, your first, your career award, then your R01 and all that kind of stuff, you're really in trouble. So you kind of got to think about, what am I going to, and then of course, once you get the grant, you have to actually do that work, right? So it's not until you're finally maybe in your 50s that you can say, you know what, I wonder if we could be working on something else. So we are trying to think about ways of doing that. I also want to emphasize, since this Simon Bacon pointed out the trivial amount that was sort of required to invest in vaccines. I mean, many people may know this, but I'm surprised it doesn't get mentioned more often. But like Bill Gates, not that I'm any fan of him, he gave the Shattuck Lecture in May 2018. It was published in the New England Journal, and it was called Pandemic Innovation. And he called for massive investments in research into presenting pandemics. And in the 19 months that followed, there was only 4 articles in the New England Journal that mentioned the word pandemic. And then guess what? Since January 2020, there's been 400. So it's like, it's not just the social determinants of health, it's even within the precision medicine paradigm. We often prioritize things that are not going to pan out as impactful on population health. I really think we need to do something about this.
Yeah, and as Hannah's bringing up the fact that an Inuk woman died homeless next to a condo development last night. She was 60 years old. She's someone who we've seen in our own healthcare system, who we knew of and who was known in our community. And this happened to her, and that we have our own local homelessness issues. And just pointing out that we can support the Native Women's Shelter, who's really in an acute need right now.
Yeah, I do. I will say that, we're seeing, and I'm sure you're seeing too at McGill, that even though obviously many of the people who are making these very kind comments are at various, stages in their career, but we're seeing more younger people are definitely into pursuing this thing. And it reminds me that Max Planck, the Nobel laureate in physics, once said that scientists don't change their mind, they just die. And a new generation comes along that basically believes, the wave. And of course, he was thinking about, people like Einstein opposing quantum mechanics. But the thing is the next generation is here, and we do need to figure out a way to figure out ways of supporting them quickly, because we don't have a generation to wait. Like, it is hard not to really worry about the state of affairs. Like, I was in Winnipeg this summer visiting my mother in palliative care during the heat dome and the smoke. And even in the palliative care center, in a really nice palliative care center in a major teaching hospital, my eyes were stinging all day. Like, I can't imagine what it's like to live like when it was 49 degrees or whatever in British Columbia. Like, imagine what that's going to be like when we have, and of course, as I'm sure many of you know, there are parts of cities like Montreal and Toronto, even though they're green in some places, there's other parts that are like heat islands where it's just like, it's noticeably much hotter. And of course, there's not access to water and air conditioning. It's like, we have to, on the one hand, start doing things in healthcare to deal with those problems, but it would be crazy to not collaborate in our research with people to prevent them happening in the first place.
Yeah, for sure. And, Kaveh is bringing up a local example of a pediatrician here who he's not a researcher, but what he did was he led the hand-to-hand campaign, which led to a change in provincial policy that now allows parents to accompany their children during transfers when they're coming from Indigenous remote communities. There's a really great book for people who want to check that out.
Yeah, actually, pediatrics has some great examples. My father was a pediatrician, and I always sort of admired pediatrics. But in Upstream, that book I mentioned by Dan Heath, they actually didn't know the history. In the 1970s, one physician met like an auto safety person, and an article in the journal Pediatrics, basically within a few years, they resulted in all the child safety seat laws. Like, it was a really interesting example of impactful work by a non-researcher clinician like the colleague that you're mentioning here. So there are some neat examples. And actually, the famous Dr. Spock, who sort of revolutionized pediatric care, he became a big proponent for nuclear disarmament. And I don't think he was sort of a researcher, he was just sort of a famous clinician. So anyway, I do think there's totally a role in academic medicine. We're trying to do that. I'm definitely not some big fan of the UT here. I grew up in Winnipeg. I was raised to hate Toronto. So, but I guess we are trying to do a little bit more to have more diversity, not just of the types of people, but of the types of research. And so we do have this pathway, the one that most of my sort of quality improvement colleagues are in. But now we have some people with backgrounds in journalism who are actually like pursuing like healthcare journalism and stuff like that. So we are trying to come up with ways, and McGill may have the same thing, but what I hadn't realized, because of some of the other places that I'd worked at in the past, the medical school was much more separated from the rest of the university. So I guess we do have this thing called creative professional activity, which is this thing that I'd never heard of before, but it's the rubric that the U of T uses for people like poets or engineers or musicians who are obviously not writing papers, but they're doing other things that show impact and sort of the external merit. And so we're trying to use that for a wider range of activities within healthcare, and some advocacy work definitely falls into that, especially when we all know that it isn't easy to do and you have to have certain training. And so anyway, I guess I'm just trying to say that I support all the comments that are being made here, and that we are trying to do something about this here. And I wouldn't be surprised if other people as well.
Yeah, Ariane Morelli is advocating for moving from patient-centered care, which was evolved by Berwick, to social-centered care.
I think he himself has made that movement himself. Actually, that essay that I quoted from for sure was like that.
There you go. And that Simon's bringing up again that it's a good example is COVID-19, which is really a matter of behavior, including getting people to take vaccines. But less than 0.1% of the global funding has gone to behavior-based research, and yet
right.
every day we hear like that a new country has purchased $2 million worth of an antiviral pill, so they're willing to put that money into treatment, but not into prevention. Clearly,
yeah.
Kaveh Desgupta is saying we really need to provide a clear academic path to support physicians who want to engage in advocacy to address social determinants. And Natalie's saying CHR should prioritize team grants that tackle these broader issues. There's so many comments, and I'm just getting to the bottom here. But I think, Kaveh is saying Bill Gates does not want to allow developing countries to license the vaccine.
I know. I wish I had not even mentioned his name, because I definitely don't support a lot of what he's doing. And he's also, for the climate crisis, is so focused on technological solutions. Anyway.
I'll sum it up with this comment from Suzanne Morin, which is thank you for this presentation, and really clearly sparked a really incredible discussion. Thank you.
Thank you. Thank you. It was nice to see all of you, and thanks so much for your time, and have a great evening.
Okay, take care. Bye.
Take care, everybody.
Fantastic. Kaveh, thanks so much.
Thank you, Mark. Great to see you again after all these years.
Yeah, good to see you, my friend. Take care.
Bye.